Okay, so here's the EKG that I want to review today. And what I want to do is bring your focus to the anterior leads. And what we'll do is we'll go over, as we always do, the same format of reading the EKG. So rate, rhythm, axis, intervals, enlargement, and ischemia. Remember, we look at ischemia last because that's really the main thing we're looking for, and especially in patients with suspected acute coronary syndrome. So we don't want to find ischemia and miss, profound bradycardia or heart block or something like this. So we go through it again: rate, rhythm, axis, intervals, enlargement, ischemia. The best way to find the rate is to find a QRS complex like this that lands on a heavy box, and then you count down to the next QRS complex. So if this next QRS complex landed on this line, the rate would be 300. So 300, 150, 100, 75. Okay, so it's a little bit more than 75, but less than 100. It really doesn't matter if you pick the exact number, but we'll say it's about 80. Okay, so the rate is 80. Rhythm, we look for sinus rhythm. Defining sinus rhythm, remember, is not a QRS complex in front of each, not a P wave in front of each QRS complex, but the morphology of the P wave. So it's sinus is seen as a P wave that's upright in 1, 2, 3, AVF, AVL, and down in AVR, which we basically have, and we'll give AVL the benefit of the doubt for this process. So this is sinus rhythm. The rate, we said, I already just erased it, is about 80. Sinus rhythm, rate 80. So rate, rhythm, axis. The axis, we look to make sure the QRS complex is up in 1 and up in AVF. So this is normal axis. Rate, rhythm, axis, intervals. Usually we'll cheat on the intervals as long as it makes sense from what you're seeing. And remember, the PR interval is 0.12 to 0.20. QRS complex, depending on what source you read, less than 110 milliseconds or 100 milliseconds. And then the QTC less than 500. And a good way to check to see if you have a normal QTC, if you don't have a printout of the actual QTC like we don't have here, is to bisect a QRS complex and see whether the T wave ends before the midpoint of the bisection. So in other words, here's these two QRS complexes, and here is about the midpoint, and the T wave ends before the midpoint. So if the T wave were to come through this midpoint here, you would say that's probably prolonged. So that's a good way, if you don't have the QTC printout, or if you don't trust it, just to see whether the QTC is prolonged. So rate, rhythm, axis, intervals, enlargement. More so worrisome for us is low voltage, and I'll go over that in a future discussion. But this looks like normal voltage. And finally, we look for ischemia. So what I want to draw your attention to is the anterior leads. Okay, so some of you may be saying that there's STEMI in the lateral leads, and you're absolutely right. There's ST elevation in 2 contiguous leads, which we see here. So V5 and V6 are contiguous. Remember, the high lateral leads are AVL and 1, and we do see worrisome looking ST segments there. But what I want to do is bring your attention to V2 and V3. Pretend like you don't see V5 and V6, okay? So let's say that was normal, and then you had V2 and V3 here. Okay, so this is indicative of an isolated posterior STEMI. Okay, so when you think about anterior ischemia, so anytime you think of anterior ischemia, just consider that this is posterior injury, posterior occlusive MI, or posterior STEMI. So, obviously it's not an ST elevation problem, but the nomenclature, we still can just say it's a posterior STEMI. And again, we're going to move away from using STEMI, move more towards a paradigm shift of saying occlusive MI, and this is diagnostic of occlusive MI. So when you have ST depression in the anterior leads, right? Just think that this is actually posterior STEMI. Just think that this is a reciprocal change of acute injury of the backside of the heart, right? And that's exactly what we're seeing here. This patient went to the cath lab and had a 99% lesion of the circumflex artery, which is exactly where you would expect to see this. Now, most of the time, isolated posterior STEMI is associated with inferior STEMI. So, if you're second guessing yourself, look at the inferior leads and see if there's inferior injury, which in this case there's not, but there's lateral involvement too. So I just want to bring this to your attention. This is all about pattern recognition and remembering that if you think that there's anterior ischemia, right, you think, oh, this guy's got anterior ST depression. It's not anterior ischemia. It's posterior ST elevation MI. And what we're going to do in the future is make it easier for you to call these as STEMI alerts. What I would, if you saw this today or tomorrow, you would call this as a STEMI alert, and we'll amend the protocol to say that that we'll call all of these as STEMI alert. So again, pattern recognition. You see this, the first thing you think of is posterior STEMI. It's not isolated all that often, but it certainly can be. But if you see this is isolated posterior STEMI. If you saw this by itself, and this patient would be a STEMI alert. So hopefully this is helpful. Please reach out with questions. We'll keep on going through these posterior STEMIs, Scarbosa criteria. I know it's confusing at first, but you just keep going through them and going through them. It gets easier, and you'll see this come across, and your eyes will catch up on it, and you'll diagnose it right away. Thanks very much.